Okay. So happy November, everybody, and happy National Epilepsy Awareness Month. My name is Erica Denicola Shear, and I am the Director of Community Education and Advocacy Coordinator for the Epilepsy Foundation of Northeastern New York. Thank you so much for being here today for the kickoff of our 2021 November Education Series, which is the first time that we've done one of these. So we're very excited about it. Every Tuesday throughout the month, we are hosting education programming free of charge on different epilepsy-related topics. On November 16th is our annual Epilepsy Family Conference, and the remaining Tuesdays are Teaching Tuesday live sessions with single topic lectures like we're doing today from noon to 1. So please be sure to check out the schedule in our flyer, which I'm going to send in the chat right now. There's a link there so that you can register for our conference and the other Teaching Tuesday live topics that interest you. Again, attendance is free of charge, and I encourage you to share this information with anyone in your networks who might be interested in attending. We wholeheartedly give thanks to this year's sponsors, LivaNova, UCB, Neurelis, and additional support from Supernus. It is their steadfast support of our agency and those we serve that allow us to plan and offer programming like this, and to offer it free of charge this year. If you would like to learn more about our sponsors, please visit our virtual exhibitor hall, which will be available throughout the month of November. It shares links to their websites and their product information and other resources that they want to include as well, so that you can learn more about them. And I also included a link to that exhibitor hall in the chat as well, so you can just click and redirect there. During today's session, please feel free to use the chat box to ask any questions you have. You can send them to everyone, which is selected right now, or if you would prefer to send it to me privately, that's fine too. And after today's lecture, I will read those questions out loud and moderate a Q&A. And we should also have a little bit of time for you to unmute and ask questions directly as well. So now, to introduce our speaker, I'm very pleased to introduce Dr. Judy Lucas. Dr. Lucas is a board-certified developmental behavioral pediatrician at Albany Medical Center with more than 25 years of pediatric experience. She cares for a large and diverse panel of patients with various developmental issues, including complex autism spectrum disorder, attention deficit hyperactivity disorder, neurogenetic disorders, intellectual disability, and cerebral palsy. Dr. Lucas works as part of an interdisciplinary team to provide diagnostic evaluations, medication management, guidance on school interventions and services, and support for older teens as they transition to adult providers. We are very grateful to have her here with us today to share her expertise on the topic of autism and epilepsy. So without further ado, I'm going to turn it over to Dr. Judy Lucas.
Thank you, Erica, and thank you to the Epilepsy Foundation for inviting me to speak with you today. I'm delighted to be here. Gonna go in here. So what I'd like to talk about today, obviously we all know that there is a well-described link between epilepsy and autism. We're going to talk about diagnostic challenges in infants, children, and adolescents with autism and epilepsy. We'll explore why identification of both autism and epilepsy are critically important. We'll review therapeutic challenges for patients and their families, and discuss some future directions in research and advocacy initiatives. So let's start with autism spectrum disorder. We know that it is a neurodevelopmental disorder characterized by deficits in social communication and interactions, repetitive movements, and repetitive I say it's repetitive patterns of speech, play, and behavior and movement, and some sensory issues. The CDC reported back in 2020 that the prevalence rate is 1 out of 54 in the United States, or about 1.8%. It occurs in 1 out of 34 males and an estimated 1 out of 144 females. And I just want to comment on this briefly. We know that males and females with autism present differently. Boys typically present with more externalizing behaviors and what we all know are some obvious features: whole body rocking, hand flapping, vocalizations. Girls often manifest their autism differently. They are less apt to have the external features and more apt to have better skills at social camouflage. So there's a lot of experts who believe that 1 out of 144 is probably an underrepresentation. Just to bear that in mind as we move forward. There are multiple co-occurring conditions that complicate the lives of individuals with autism. About a third have intellectual disability and about a third are nonverbal. Many have adaptive delays. I want to comment here briefly. The adaptive delays are really something that is drawing a lot of attention, especially as our young adults and older adolescents move into young adulthood. The adaptive delays are significant and they persist. And there is some data that shows the adaptive delays can almost even worsen over time. It's also well described that, and I'll comment later, many individuals with normal cognition with autism have adaptive scores that are 2 and even sometimes 3 standard deviations below their cognitive potential. So the adaptive delays are significant. And obviously you can imagine if you're an individual with autism and epilepsy, those adaptive delays really need to be well identified to keep these kids safe. An estimated 30 to 60% of kids on the spectrum have comorbid ADHD. More than half, some studies it's about 60%, have chronic sleep disturbance. And again, underlining that, we know that appropriate sleep, proper sleep is important for seizure safety and seizure control. So that can play a big role. 40% have an anxiety disorder. Depression is more common. 7% of kids, 26% of adults have comorbid depression. And again, that even may potentially be an underestimate. 45% have disruptive mood dysregulation disorder. And an estimated 25 to 60% of kids with autism take 1 or more behavioral medications. I'll comment in a little bit about how that gets tricky when it comes to management of anti-epileptic medicine. Meds interact, and anti-epileptic meds can have behavioral side effects. So it can get a little complicated, but just know that many kids are treated with behavioral meds. Back in years past, the drug of choice was stimulant. It was very unusual for me to meet a new kid for a rule out autism kind of evaluation that hadn't had at least a trial on a stimulant or 2. Now the most common group of meds used for kids on the spectrum are the atypical antipsychotics. Okay. So we know that there are links between autism and epilepsy. Roughly 2 to 3% of the US population has epilepsy. And I want to point out that epilepsy is more common than autism, Parkinson's, MS, did I hit that? Autism, Parkinson's, MS, and CP combined. So epilepsy is pretty common, 2 to 3%. In children, roughly 20 to 30% of kids with autism develop epilepsy before they reach the age of adulthood. And in 25 to 40% of adults with autism have epilepsy. For kids, there's two peaks. There's the infant peak, and then there's a secondary peak at around ages 10 to 14. Roughly a third of kids with childhood epilepsy screen positive for ASD. So bear that in mind. If you have a child with developmental delays and epilepsy, take a close look at their social interactions and their behavior, because a third of those kids you could diagnose with autism. In females with autism, they have a higher seizure risk, which is important to underscore. And again, you have a higher risk in autism with intellectual disability of having epilepsy. Those two go hand in hand. I always counsel my families as they near early adolescence, if they're a kid with autism and intellectual disability, that's sort of the target group. That's the group you need to keep an eye on. So as I said, the severity of the intellectual disability is correlated with epilepsy. And we know in that population, they have a lower IQ, lower adaptive skills, more motor problems, and ultimately they are at risk for having worse social and behavioral outcomes. I want to speak briefly about autistic regression. It's always been said that about a third of young kids with autism experience a language regression. That group of kids in particular is at higher risk for epilepsy. So again, that's a population you're going to want to keep your eyes on. Okay. So there are different seizure types. Without this being an exhaustive review of neurology, I think it's relevant to my remarks today. Most cases of epilepsy in children present after 10 years of age, and all seizure types have been reported. They may be focal or generalized. They may be simple or complex, where there's an alteration in the level of awareness. And generalized seizures can be convulsive or non-convulsive. It can look like the stereotypical tonic-clonic seizure, or they may be a little more subtle. Symptoms can vary widely. There may be stiffening of the body or extremities. There may be twitching. The child may suddenly lose muscle tone, drop their head and become limp. They may have sudden jerks, that's termed myoclonus. They may have staring spells, lip smacking, or other non-purposeful movements. Or they may present with behavior arrest, where there are distinct changes in behavior, such as staring, emotional changes, autonomic changes, or just, catatonia or cataplexy, where there's just a lack of movement. These areas can be very tricky to ascertain in a child with autism. So I often get asked, what's my child doing? Is it a tic? Is it a stereotypy? Or is it a seizure? The best thing I tell parents to do is, if you can grab it on your cell phone and show me or send it to me, that can be really helpful. Or, sometimes teachers or therapists see something that warrants concern. The biggest thing for me is if it's a new behavior, I'm more concerned. If it's something they've never, ever seen before, I'm more concerned. If it's episodic and discrete, it has a start and a stop, I get concerned. Or when it stops, is there some type of post-ictal phenomenon? Is the child sleepy or out of it or different, spacey, doesn't seem to remember what was going on? Then I'm concerned. What are tics? Tics are, again, repetitive movements, usually eye blinking, a facial grimace, some sort of repetitive facial movement. There may be a vocal component, which would indicate maybe Tourette's syndrome. It's worth noting that 25% of all kids in childhood at some point have a tic. Then odds are higher if you're on the spectrum. About 40% of kids on the spectrum tic. These tics usually show up early in childhood. There's like a preschool kind of blip where you start to see it. Stereotypies, on the other hand, are commonly seen in kids on the spectrum. The most common would be things like whole body rocking, hand flapping, repetitive hand movements, head shaking. Those are the most common ones. And then the seizure types we just discussed. There can be a lot of overlap. But again, my cardinal rule is if it's brand new, no one has ever seen it before, it's episodic and discrete, and there's a change afterward, that to me raises concern about a possible seizure. So there are diagnostic challenges. Individuals with autism often exhibit behaviors that can be confused with seizures. And it's not as simple as let's just get EEGs on these kids to figure it out. Up to 60% of kids with autism have abnormal EEGs. So an EEG may not straighten it out. Extended monitoring with EEGs has its challenges in this population. If you think about a child with autism who has an intense need for sameness, they have a hard time when they're either sleep deprived, the routine changes, they can't get the same foods, they have people, they're highly resistant to meeting new people or having new experiences. You can imagine what a 72-hour extended stay EMU hospitalization can look like for these kids. Very challenging. So what do? We rely on the skill and expertise of neurologists to guide diagnostic and therapeutic decisions on these kids. And I can't underscore it enough. Observation and symptom reporting by parents, teachers, and therapists is really, really important. I'll tell a quick story to illustrate this. I had a young man a couple of years ago with intellectual disability, nonverbal autism. He got to be about 6 or 7. And he had previously done pretty well in school, not a lot of behavioral difficulty. And then I want to say he hit 1st or 2nd grade, and boy, things were different. He was irritable, aggressive across settings, totally different, an abrupt change. And, we chalked it up to new school, new teachers, new bus, new routine. We chalked it up to a lot of other things. But on push, really pushing the history with his mother, he was having episodes that were new and discrete and different. And he would have these episodes multiple times throughout the day, and they were characterized by inappropriate bouts of laughter. When there was nothing humorous, there was no trigger, but he was having laughing episodes. And that is that's a finding in something called gelastic seizures or gelastic epilepsy. It's extremely rare, but that he was having gelastic epilepsy, and the EEG supported it. And in retrospect, it had been going on for a while. So and teachers and parents had seen it. They just thought he had, funny thoughts in his head, and it was one of his stims. But again, to underscore, observation and reporting of unusual symptoms or behaviors is just, it's always a good idea. So why does this matter? When I meet a kid, I'm always looking for the comorbidity. I'm always looking for that thing. I got 5 things that this syndrome is associated with. That's where I put my effort. So if I've got a kid, a young infant with developmental delays and seizures, I'm always scratching my head, making sure I'm not missing autism. Why? It's important for programming. It's important for parents to understand their kids' struggles, and it's appropriate. It's important for planning, but without understanding the autism piece, these kiddos can often go years without receiving autism-specific related services. On the flip side, the other blip in early adolescence, often by then the autism's been diagnosed, and we know about their developmental difficulties. My question is, are we missing seizures? Make sure we're not missing seizures. And it's important from the standpoint of seizure safety and their adaptive skill development. Ultimately, I want to get these kids out and on their own. If that's a reasonable goal, we have to make sure they understand their epilepsy and that they have the organizational skills and the fine motor skills to take care of their seizures appropriately and safely down the road into the future. So that's why this matters. So during infancy and childhood, I take care of many kids with neurogenetic conditions that often present with seizures early on. Number one, tuberous sclerosis. It's a condition, a genetic condition marked with tumors in the brain and often in the heart. They're often diagnosed prenatally. High associations of significant developmental delay. These kids often present with infantile spasms. Angelman syndrome, inherited on the maternal chromosome 15. These kiddos often present with developmental delay in epilepsy first, and then as time goes on, you see the features of autism kind of start to emerge. Rett syndrome affects 1 out of 10,000 girls, some boys, mostly girls, marked by the MECP2 mutation. The hallmark for Rett syndrome is developmental regression and signs of autism in a girl. They should be evaluated for Rett. And then I want to talk about SCN1A mutations. They cause refractory seizures, very hard to control seizures, and developmental delays. We know that's how they present early on, but the autism piece doesn't start to emerge and get called out until a little bit later. A lot of my patients from the NICU, I do a lot of the long-term NICU follow-up, and these kiddos are at particular risk. And sometimes families aren't aware of the autism risk. So that's why I wanted to bring it up today. I take care of a lot of kids that have hypoxic ischemic encephalopathy as infants for whatever reason, birth asphyxia or other medical reasons. Kids have brain damage early on in infancy. And those kids we know are at risk for developmental challenges. They are at risk for epilepsy, but they are certainly at risk for autism. Kids who have congenital infections, congenital cytomegalovirus causes hearing loss. Perinatal infections, all our babies that have meningitis and encephalitis are at certain risk for developmental issues, but we have to keep our eye on the ball with respect to autism for those kids. Our ex-preemies, to give you a number here, years ago, I haven't seen updated data, but if you were born at or before 29 weeks, your odds of being on the spectrum about 1 out of 20. So the way I think about it, it about doubles the risk. Our kids with brain bleeds, interventricular hemorrhage, our kids with shunts, all of these kids are at higher risk for autism. And then our kids that have brain tumors, our kids that have trauma, either accidental or non-accidental trauma. All of these kids are at higher risk for having both autism and epilepsy. And again, to point out, knowing that autism diagnosis can be really important. I often get kids who send in with what to me looks like pretty obvious spectrum. You know, there's a lot of stereotypies, repetitive movements, intense distress with change, food selectivity, all the calling card behaviors. And when I bring up autism, people seem a little shocked because they kind of think, well, my child inherited developmental delays and epilepsy. That went as a package. And the autism often comes kind of surprising to them, unfortunately. And I think sometimes it delays services. I see sometimes kids, 4 and 5, they could have been getting really good support and care for their autistic difficulties for a couple of years. So that's why I bring it up. I also think sometimes, certainly I feel this way sometimes, you say, oh, do I really want to lay one more thing on this family? Do I really want to, they're getting good services, he's getting all his therapies, or she's getting all their therapies. Is it really important that we call out an autism diagnosis? And I often believe it is, because there's different therapies we'll talk about that can help. Specific special ed, specific behavioral support, social skills and social developmental opportunities can be really helpful for these kids. So what are the signs of autism in infants and young children? Often repetitive movements is your first clue. And what we know is 3 or more repetitive movements in the first year of life impart a 5-fold increased risk for autism. If the child responds inconsistently to their name being called, if there are repetitive patterns of play and a need for sameness, if there's indifference to other children or a strong preference for solitary play, food selectivity, and a language delay accompanied by a lack of gestures. There are some childhood conditions that predispose to autism and epilepsy. First is Fragile X. It's important to know about. It's the most common inherited cause of autism and intellectual disabilities, and it affects 1 out of 4,000 boys and 8,000 girls. These kids have a higher risk, 10 to 20% have epilepsy. And it's highly associated with autism to the tune of about 60%. Down syndrome, most people don't realize, have a higher risk for epilepsy, 1 to 13%, and they have a higher risk for autism. Some people aren't aware of that. Upwards of about 20% meet the criteria for autism spectrum disorder. So what services do kids need? Speech, not just for receptive and expressive language, but to focus on the pragmatic use of language. How well does the child use communication and speech as a means to form and maintain relationships? OT can be extremely helpful, not just with fine motor, but with feeding and with the sensory issues these kids have. And physical therapy can be vitally important. Many kids with autism have significant gross motor delays that persist. They often have truncal weakness and poor motor planning that may not necessarily be recognized. So those services can be important. Special ed and specific strategies to improve joint attention are key. Probably the biggest thing I can do for a newly diagnosed child with autism is get them into a small classroom. These kiddos have a really difficult time in loud, noisy, crowded situations. And they need often one-to-one or shared adult support. They need somebody at their elbow to help them transition and to help them pay attention and be safe. Other therapies like music therapy, art therapy, and then our sensory therapies, sensation therapies, vision and hearing can be really important. Social skills training and support, not necessarily just teaching a child how to act, but to immerse them in experiences where they can interact with same-age peers in a supportive way can be key. Parent training and community resources are vitally important. And things that kind of go outside of the scope of just having a child with delays and seizures. Services through OPWDD can be extremely helpful. And, having a whole nother avenue of support and community support. The autism community they do a lot. There are a lot of resources. So being able to tap into that can be really helpful. Another thing to remember is kids on the spectrum have some differences, and they have some medical vulnerabilities. They can be highly food selective and can get into trouble with some nutritional deficiencies if you're not careful. They often have difficulties with elimination to the tune of easily 60%. Have difficulty with constipation, which can impact toilet training and other adaptive skill development. And then sleep can be really problematic for kids on the spectrum. All of these things can impact seizure control as well if you've got a little kid who is stressed out. So the two go hand in hand. I want to talk about early adolescence. Adults who are responsible for kids and teens with autism should be aware of their increased risk for seizures. They should take note of unusual behaviors, again, especially if episodic. It's not always obvious, generalized tonic-clonic seizure activity you're looking for. It can be posturing, staring spells, or just unusual episodic behaviors, changes in mood, and then the decline in function, like the anecdote I shared, should warrant concern. We need to, of course, though, balance the child's need for autonomy with being safe. So what are some measures for seizure safety for children and adolescents? Most important, the family should learn first aid, and the child should have a medical alert bracelet. The school should have a seizure action plan. The child needs to be carefully supervised around water to the point where eyes aren't really taken off, okay? They should be advised to take showers instead of baths, especially if they're doing so privately, and reinforce the recommendation that bedroom and bathroom doors should be left unlocked. The importance of proper sleep cannot be underscored enough. And again, if you're a kid on the spectrum, sometimes initiating and maintaining proper sleep can be really tough. So it needs attention. Sometimes we use meds to help kids fall asleep and stay asleep. They need to adhere to their medication regimen. So the more parties that are weighing in on this the better. They should avoid unprotected heights and always use a helmet when riding their bike, no matter how old. So some of the therapeutic challenges of all of this. Certain behavior meds can potentially lower the seizure threshold. Meds we commonly use, the stimulants can do it. the atypical antipsychotics can lower the seizure threshold. It's usually not problematic if the seizures are well controlled, but if they're not, it can sometimes make my job a little bit trickier. Other consideration is behavioral meds can interact with anti-epileptic drugs. So I may have a child who is perfectly seizure-free on their AED, on their anti-epileptic drug, and lo and behold, I add a med, a low dose, I think it's going to be fine. I've altered his metabolism, all right? Maybe I've induced an enzyme that metabolizes both, and lo and behold, he's no longer therapeutic on his AED dose. Okay, so that gets tricky. The atypical antipsychotics, like I said, they're the most common drug used now for people on the spectrum. Number one problematic side effect is they can cause rapid weight gain. So if I've got a kid with epilepsy, well managed on his AED dose, he's beautiful, he's been stable, dose, titrating up nice and slow with his weight. All of a sudden, I give him, an atypical, and he puts on 15 pounds. Now he's subtherapeutic. So that can be tricky. And then our anti-epileptic drugs can cause behavioral side effects, agitation, worsening of mood, and sedation. And sometimes these drug combinations can be tricky. One can potentiate the other. So it's not just, giving an antibiotic and, we can give asthma meds and antibiotics and it all works well. This gets a little complicated sometimes. So there's some other challenges. We know that folks on the spectrum have sensory differences. Sometimes palatability can be a real problem. And if you've got a child that, fights to take meds, compliance can be a big issue. Like I said, the adaptive function is often much worse than you would expect for a child's cognitive level. Those adaptive delays can persist into childhood and can impact adherence to medications, in particular the AEDs. Kids on the spectrum, teens and adults on the spectrum have executive functioning deficits. So if you think about the executive functions you have to have in place to adhere to your seizure med regimen, you have to be organized, you have to plan. Those are two of the big executive functions. So if you're a 21-year-old with autism and your organization and planning aren't so great, are you going to remember to take your meds? Are you going to set a timer? Are you going to make sure you go for your neurology follow-up appointment? Are you going to make sure you have your meds? Are you going to tell the doctor the right pharmacy? They sound like little things, but they can be problems if the adaptive skills aren't addressed early. Kids on the spectrum have rigid thinking. So many teenagers and young adults with autism, if they don't view the med as beneficial, you may have difficulty changing their mind about it. If they perceive that they have a side effect or they may get a side effect of a medication, an unwanted side effect, they may stop adhering to their medication regime. And then all the other healthy lifestyle recommendations that reduce seizure risk, like getting proper sleep, like turning your video game off at midnight so that you get proper sleep, like not going out with your friends, so that you get good sleep. Being abstinent from drugs, marijuana, alcohol is key in keeping our older teens and young adults safe. Having autism can impact your ability to size up risk and make good choices when you're presented with temptations that may not really be the best for you. In terms of areas of future research, the big concern that we worry about in older teens and young adults is sudden unexplained death in epilepsy, or SUDEP. Is believed to be responsible for 4,000 deaths in this country annually. And most victims are 22 years of age and younger. It's 20 times more common in people with epilepsy. And we know that people with autism have death rates about 2.5 times that of the general population. The most common causes of death in autism are drowning, seizures, and then unknown. It's believed that this unknown category probably represents some unexplained death in epilepsy. These, unfortunately, it's hard to talk about. These are probably kids that seize in their sleep and die. We know that there's a particular duplication of 15q11 that predisposes an individual to this risk, but this is certainly an important area of future research. Experts have been directing providers like me for better part of 2 decades now to do genetic testing on our kids with autism when they're diagnosed, just so we can better identify the risk. Originally, it was thought if we could get a genetic handle on these kids, we'd be able to figure out which therapies work and which therapies don't. That hasn't really panned out, but this is an area of definite concern. If we can determine which genetic conditions predispose to epilepsy, and more importantly, which predispose to SUDEP, that would be a really important area of research and with direct clinical implications. And I want to highlight an area of advocacy that's being brought forward by the Epilepsy Foundation. They've launched a nationwide initiative to improve seizure safety in schools. To date, I believe that 18 states have passed this, and there's an effort to bring this to the New York State government in the future. There's 5 parts to this legislation. The first requires school personnel to complete a seizure recognition and first aid response training. They want to mandate that the seizure action plan is part of the student's file and available to all personnel who are responsible for the student. We want to ensure that any FDA-approved med for the child prescribed by a physician is administered. We want to educate and train students about epilepsy and first aid response. And we want to include a Good Samaritan clause so that people won't be afraid to help a child who is having a seizure or is at risk. So in conclusion, we know that there is an association between autism and epilepsy across the lifespan. Identification of autism in children with epilepsy is important, so we ensure that they receive appropriate programming and services. Identification of seizures in children and teens known to have autism is important to protect their safety and promote necessary adaptive skill development. And future research and advocacy efforts are needed to keep the epilepsy community safe. So those are my remarks. That's what I wanted to share with you today. I'm open for questions.
Thank you so much, Dr. Lucas. That was a really, really great talk that you just gave. And I know I learned a lot. So we appreciate your expertise very, very much. I didn't see any questions come into the chat, but if anyone has a question now, I would invite you to use the reactions button to raise your hand, and then I can invite you to unmute just so that we don't have people talking.
Oh, can I just ask something?
Oh, sure.
I have a daughter who is an adult daughter with autism and seizure disorder. So I guess this is most like related to children, which I've been through all these steps, but I'm just wondering what would be my best resource right now to help my adult daughter.
For where is she? Is she home? Does she live?
She works. Yeah, she has a job. She works. She has had a seizure once a year. In the last 3 years, and she uses Oscar Banzepen. I can never pronounce it, but she has her pill box and been able to keep them under control. But of course, that there are issues. There's always a worry. I mean, there's the issue of driving, for example. Normally she's allowed to drive, but her neurologist said, well, let's do another EEG. So we're waiting for the results, and it's very important for her to drive, but we're going to see what the neurologist says. And I'm just looking at the future and just concerned about what the future holds for her and how she's going to live. Will she be allowed to have children? I heard that medicine is not to be taken if she were to become pregnant.
Okay.
So it's a lot of concerns about, but she is able to, for the first time, she's 28, she has a full-time job, and apparently there's some stress, but she's holding to it, and so we're happy about that.
That's great. You've done a great job. Wow. Really great job. I am happy to have a broader conversation offline. Erica, you can maybe connect us.
Yes,
That would be
absolutely.
wonderful.
I'd be more than happy to do that. And the other thing too, does your daughter live in like the northeastern New York area?
I'm right in Niskayuna.
Oh, perfect. So the other thing I'd recommend is having her reach out to our office. There's some resources that we can probably provide. And, another thing that might be of interest is actually a previous webinar we did about women with epilepsy, and we have that recording available. So I can provide that to you also. So I'm going to put my email address in the chat right now for everybody. So I would I probably have your email from the registration, so I'll make sure that we connect, but also feel free to take mine down, and
yes,
we'll get you connected with Dr. Lucas and also our organization.
And see, a major concern I have is that here I will do what I can, but she is very eager to not look different. And in fact, for the longest time, we have, I wouldn't say hit the problem, but sort of not emphasize that she is different. And she, how should I say, she doesn't even think she has autism. She thinks that, well, okay, she has accepted I'm on the spectrum, but she's not, what I'm saying? She's functioning, okay? And so it's very hard for her to do the sort of thing I'm doing right now. I would even be afraid to talk to her about, getting help for the future, because she wants to be normal, and understandably so. So, I think long term, when I'm not there anymore, because I work part-time, and I spend a lot of time with her. She doesn't have many friends, so I take lots of walks, and I'm just really there for her, but I'm not going to be around all the time, so yeah.
Well, you've done a great job, but there's some support, because as kids get older, they need to be less reliant on us and more reliant on others.
Right.
So I can help you with that.
Thank you.
Me too. So we'll connect after and definitely get you in touch with those resources.
Awesome. Thank you so much.
You're welcome.
Mm-hmm.
Are there any other questions that anybody had?
Yeah, types of partial in the context, generalized. We have a few minutes. Generalized, mean, petit mal. This is all questions regarding like seizure nomenclature. So simple, partial, complex, partial, really just in this context means simple versus complex, tells you if there is an alteration in level of consciousness. Simple or partial, let me make sure I got this right. Simple and complex relates to if there is alteration in consciousness. Partial versus generalized means how many parts of the brain are active in causing the seizure. So if it's partial, they used to call that focal. So it, maybe starts in, the right frontal cortex and then generalizes, it spreads. What is the difference between petit mal and grand mal? Petit mal, they used to call absence seizures or absent seizures. Those are characterized by staring. Maybe there's an associated facial movement. What we call automatisms, where the individual may fumble with their clothing, versus grand mal, which is sort of the classic tonic-clonic seizure. The person has whole body rhythmic jerking. They may have difficulty protecting their airway, may last for minutes. And then there's generally a post-ictal state where the individual is sleepy and difficult to arouse. Controlled versus uncontrolled seizures, that's a term meaning that your overall assessment of seizure control, meaning that you may have infrequent seizures versus an uncontrolled seizure disorder is someone that has frequent seizures with a significant impact on their day in, day out life.
And I'm putting into the chat right now. So as the Director of Education for Epilepsy Foundation of Northeastern New York, if anyone is interested to learn more about epilepsy specifically, different seizure types, how to recognize them, the first aid response, that's something that I can set up with you individually. We also have a monthly seizure first aid certification webinar, which I am putting into the chat right now. It's free of charge. It's the first Wednesday of every month, meeting tomorrow. So if anyone is interested in becoming seizure first aid certified in the month of November, which is Epilepsy Awareness Month, you can still register for that. It's tomorrow at 3 p.m. And as I mentioned, it is free of charge. So the registration link is now in the chat for everybody as well. Thank you for that question. All right. So if there aren't any further questions right now, that's okay. If you come up with a question after you're sort of thinking and reflecting on what you've learned today, do also feel free to shoot me an email. I'm happy to pass the question along to Dr. Lucas and send you back the answer that she gives. So please don't hesitate to take down my email and let me know what questions you have. If you are interested in education, resources, anything like that, that's what I'm here for. So before we sign off, I do just want to say thank you again formally for attending. And don't forget to check out our flyer with the rest of our programming for this month, especially our family conference on the 16th and our exhibitor hall highlighting our sponsors. So with that, I hope everyone has a really good rest of your afternoon, and thank you so much again, Dr.
Thank you
Lucas.
very
We
much.
really appreciate your time.
Thank you very much.
Thank you. Okay.
All right, take care, everybody.
Bye.
Bye.